So today we have Jesse Cole. He is president of InterLutions, and he is here today to talk to us about group healthcare insurance for credit union employees. With group healthcare, we can work together to drive down medical insurance costs. During our webinar, if you have any questions for Jesse, please either unmute yourself and ask your question, or you can add your question to the chat functions. And thank you everyone for coming today. And Jesse, we appreciate you joining us, and we're very excited to hear more about what you have to offer.
All right, thank you so much, Christine, and thanks to the Association of Vermont Credit Unions. It's great to be with your credit unions today. Also want to say hello and thank you to Jackie over at CUNA Strategic Services. We partner with CSS to deliver our services to the different leagues and associations across the country. So it's been a great opportunity getting to know Jackie, her team at CSS, and a lot of different leagues and associations. And this has been a hot topic, healthcare and employee benefit costs and services. Our QSO is all about collaborative models. So we really leverage the industry's collaborative strength to drive down the costs of healthcare. And we have some pretty interesting models and case studies that we'll share today. One specifically that we really want to put in front of credit unions to help you all evaluate this program. So again, my name is Jesse Cole. I'm the president of our QSO at InterLutions. I've been in the credit union field now for 19 years, and it's been great working with so many credit unions and seeing a lot of growth and a lot of excitement throughout the movement here. So with me today is Ryan Staub. He is our credit union practice leader, leads our service team, and has really been instrumental in putting together a lot of these services for credit unions. So thanks for joining me, Ryan. Ryan's going to co-lead the presentation. I'm going to turn controls over to him in a few minutes. Let me advance slides here and just show you a quick recap of our discussion here this afternoon. Always starting with why. I think we all know why. It's been a very challenging battle against the rising medical insurance costs, and the trajectory continues to be a very steep curve and go up and up and up. So we need to find something to do about that. And again, that's why our QSO exists. I'm sure that's why many of you are here as well. I think the most important part of our discussion is the how. We want to really present to credit unions, how we're handling employee benefits, our collaborative models, our purchasing efficiencies, what we call cost containment or active management. You'll hear those terms throughout our presentation as well. In the insurance world, as most of you probably know, the law of large numbers certainly sticks more than a lot of other industries. Insurance underwriters like volume and scale when they're pricing out renewals and premiums. So our best bet as an industry, our belief is that through collaboration, we can really work together. So we're putting together some interesting programs that allow credit unions to collaborate and leverage their numbers, leverage their health, and we'll show some interesting data and statistics behind that of how this has been successful. And last, we'll talk through the service and support. So there's really three components that we want to reference today is, again, how can we leverage purchasing efficiencies to drive down costs? How can we put together resources for your employees and dependents to really find some cost containment models through what we call active management? So knowing that 80% of your costs, of all healthcare costs, are typically driven by about 20% of the insured members on the plan. And we know that well over 80% of pharmacy-related costs are driven by only about 5% of the employees. So how can we really help those employees that need it the most? And we have some really good partners, some good service offerings that help you as a credit union and help your members as well to really drive down some of those high claims costs. And last, we'll get into the evaluation process. What does it look like to evaluate our solution? There's really no risk, there's no requirement to join, but again, hopefully you'll see some value in this and at least take a look at the product and see if it might be a good fit for your credit union. So we'll talk through that as well. So with that said, we will get started here. So again, why? A lot of these graphs look somewhat similar, I'm guessing, to many of you when you look at healthcare costs, medical insurance costs, premiums, deductibles, how fast they are rising. This graph just simply shows how fast employer premiums and deductibles are rising compared to workers' earnings and inflation. So it's a scary trajectory. It's a scary proposition. So we really believe that we can't be doing the same things over and over and over again and expecting different results, right? We call that the definition of insanity. So a lot of credit unions have looked at changing carriers, changing brokers, changing plan designs year after year, and sometimes that helps. Sometimes there can be a good band-aid approach here and there, but typically, if we continue renewing in our same models, this is the that trajectory. This is the graph we're going to continue to look at. So our model is a little bit different, and that's what we want to present to all of you today. So again, focusing a little bit on the why, we have some interesting data that shows credit unions, at least our book of business, which is a pretty good chunk of credit union employees, their health compared to other industries. So this benchmarking claims analysis shows the industry per employee per year claims costs. So PEPY is per employee per year. So you look at the industry related costs per employee per year, you'll see financial services kind of right in the middle. The industry average is about 12,600, and you'll see at the bottom the eye care, the credit union group that we work with, about $9,684. So that's 23% difference. That's a big difference, and we'd like to leverage that number. We think moving credit unions into a healthier pool, moving them away from these what's called a community rated pool that you're typically lumped in with a lot of other employers, a lot of other industries that are really dragging your numbers up. It's costing you more to be in those pools. So we want to pull credit unions away from those pools and put a healthier population together to really drive down costs. And we're leveraging a lot of good data to do that. So we really think this is an interesting number. This wasn't a big surprise, but it was a bit of a surprise for us as we peered through these numbers over the past couple of years. We really like this report, and it's something we really try to leverage with carriers. So I want to talk through a little bit of what might be broken in our healthcare system right now, because it really sets up how we're doing things a little bit differently at our QSO. And then I'll turn controls over here to Ryan again to get in a little bit more detail about self-funded plans, about what insurance captives are, and how that model is really what we believe much better for credit unions. So what most credit unions are utilizing right now is what's called a fully insured plan. Usually credit unions and all employers under 200 or 300 employees are typically on what's called a fully insured plan. And in the simplest form, what that really means is credit unions and employers are transferring all of their payment, all of their risk over to the insurance carrier each year, and they're paying fixed flat premiums on a monthly basis for their annual renewal. So no matter if it's a high cost medical claim or just a scraped knee or a routine doctor's visit, you're paying insurance for every one of those claims and you're transferring that over to the insurance carrier. I think the only perceived benefit of a fully insured plan is that it's a flat fixed monthly payment every single month, and it won't fluctuate throughout the year. But we all certainly know when we have those annual reviews, and if we have a difficult year, we certainly know at the end of each year our costs continue to go up and up and up. So there's a lot of downsides of what's called a fully insured plan. One of the biggest ones is you're really not getting much claims data in reports. So we really have no idea what's driving our costs up. And typically about 60 days prior to your annual renewal, you're getting your numbers back. They're always increasing. And you really have no idea why. And I think worst of all is you don't have a lot of time to make any strategic decisions. So we're waiting for these reports, we're guessing what that's going to be. And by the time we have our information and our renewal numbers, if they're really high, we just don't have enough time to do much about it. Another downside of what we really believe in the fully insured plan world is the insurance carrier always wins. And what I mean by that is no matter what, if your claims are lower than expected, that's great. That means your employees had a healthier than expected year. But what that also means, because you have a fixed premium and payment to the insurance carrier, they're profiting on that. They're retaining all of that profit. If your employees aren't using the healthcare facilities like they expected you would, they retain all that profit, which is really unfortunate. On the flip side, if your employees have let's say a difficult year, higher than expected claims costs, now, it's great that your costs are fixed that year, but we all know what happens is you then will receive a 20 or 30 or 40% increase that following year. And I think worst of all is that is now your new baseline. Rarely, if ever, is an insurance carrier and broker going to come back and say, hey, you had a great year. We're going to reduce your costs by 10 or 20%. It just really doesn't happen. It's always going up and up and up, and it's always benefiting the carrier. So we want to flip that model around. I want to just cover a couple more slides. I want to pause for any questions, then I'll turn it over to Ryan to get in a little bit more detail of what this means. But we want to flip that around. We offer, again, more collaborative programs through a self-funded model through what's called an insurance captive. And insurance captives have been around for a number of years. We have a plan up and running for larger credit unions that's worked really, really well. And essentially what a captive is a group of like-minded employers, in this case, credit unions, forming their own insurance company to fund a portion or a percentage of your employees' medical claims. So instead of transferring the payment over to the insurance carrier and buying insurance for those claims, we're actually funding that ourselves as a group of credit unions. So there's a lot of tax benefits. There's a lot of efficiencies and purchasing benefits in doing that, because again, we're not paying all that margin, the tax, the fat that's built into insurance costs. So that's really what a captive is. We'll get in a little bit more detail of what that means and how it's really different than what most credit unions are doing in that fully insured model. So I mentioned self-funding. Self-funding, again, is not a new mechanism. It's typically only thought of for the largest credit unions, but through collaboration, through some of the programs we're putting together, it really is more affordable and more viable for credit unions that have as little as maybe 10 plus employees. And even the smaller ones, we can certainly still take a look and see if that's a viable product, but it's really a good fit for small, mid-sized credit unions. So what self-funding really means is the credit union is actually paying for a small percentage of your employees' smaller claims costs. So the credit union actually has a deductible and you're paying out of pocket for a percentage of your employees' claims. And again, much more efficient way to fund your claims as opposed to just transferring all that over to the insurance carrier and paying a lot of tax and excess margin and profit for that. So again, essentially that's what self-funding is, but what inherently comes with a self-funded model is that access to data. So we can actually see what's driving our costs up. We have more claims reports. And I think even best of all is we can leverage that claims data to really help those employees, again, that need it the most. If we're getting that data, we know what our renewal numbers are going to look like. We can really put together longer, more strategic plans in terms of trying to really drive down our healthcare costs. I mentioned the term captive. What we like about a captive model is it lowers your risk of high renewals, and how we do that through collaboration is we look at, we'll call it an offsetting factor. If we have, for example, 20 credit unions in an insurance captive plan, we always know that a small handful of those credit unions are going to have a very difficult year, higher than expected claims, and a small handful of credit unions are going to have a very good year, much lower than expected claims. And the rest of the credit unions have a pretty common normal year. So the averages all really weigh out and you see less volatility. You see less of the 20, 30% increases when you are with a larger group of employers. When I mention that offsetting factor, it's oftentimes different years. So year 1 or 2, one credit union might have a difficult year, but year 3, 4, and 5, that credit union might be having a very good year. So it's really credit unions collaborating, helping each other out, really driving down costs for all of the credit unions in that plan. It's really what we like about captives. The other model of why we like captives so much is, as I mentioned before, in a fully insured world, the carrier always wins. In a captive model, again, it's credit unions that have ownership in this insurance company, and the credit unions then can actually retain the refunds, the profits, the surpluses at the end of each plan year on a prorated basis. So again, those refunds are not going to our QSO. It's not going to any of our service partners. It's going back to the credit unions that have ownership in that captive, and it's why we really, really like that model. So we'll get in a little bit more detail about what that means, but overall, we believe, and we have data and proof, captives have been around for a number of years. Credit unions that are joining these types of collaborative programs are really seeing lower and much more steady annual premiums. So I shared a lot here. Let me take a quick pause before we go to our next section. Ryan will get into a little bit more detail of the purchasing efficiencies involved in both captives and self-funding. And then we'll switch over to what I'd mentioned before, the cost containment side. How can we put together resources for your staff and your employees to really help drive down some of those high claims costs? So quick pause, feel free to type any questions. Let me check the chat feature to see if there are any questions typed in. Feel free to unmute if you would like. I'll take just a few seconds here. We'll certainly leave time at the end as well. And then I'll turn it over to Ryan. So Ryan, let's give it a couple seconds and then feel free to take it away over these next couple slides.
All right, I think we'll take that silence as no questions so far, but feel free to chime in as we're moving along here. So, I think Jesse, provided a great overview of self-funding. Just to better define a little bit what self-funding is, essentially the core concept behind self-funding is that you're retaining more of the known and expected claims, about 70% of the claims that occur every year, whether it's colds, coughs, flus, sprained ankles, so on and so forth, that you're going to have every year regardless. And why transfer that known risk off to an insurance company who has profits and overhead expectations, and rather than that, just retain that portion of the claims and transfer the rest off to something referred to as stop loss insurance. So above a specific threshold in claims for each employee, buy catastrophic insurance that's really going to come in and pay for those claims that occur there. So inherently, there's just more efficiency built into that type of model as a result of eliminating the insurer taking on a good portion of that risk. So, the downside to a smaller employer, and I'd really categorize smaller employer as anyone less than, say, 100 employees or even 150 employees, is that the volatility can be relatively significant on a month-to-month basis. And by that, I mean, you could have 2 months in a row with relatively low claims, and then you all of a sudden hit, month 3, 4, and 5, where more employees are going to see the doctor, so on and so forth. That can really create quite a bit of volatility month to month, as well as Jesse touched on earlier, year 1 and 2, you have great claims experience. 3, 4, and 5 aren't so great. The captive structure really helps a whole lot with the latter aspect of that. The real reason, though, that I get most excited about self-funded plans, and I think the credit unions that we work with like self-funded plans so much, is the data. That as you get access to information of what's really driving claims, it puts us in a position to where we can consult with our clients and guide them to, put programs in place that ultimately help the plan run more efficiently. And it helps not just the employer from the perspective of managing costs, but it also helps the employee pretty significantly as well, which we'll get into quite a bit more detail on. Final couple things I'll just mention. Some tax savings as a result of a self-funded plan of taxes that are built into fully insured or fully funded plans that don't apply. And again, just this concept of buying less insurance tends to be quite a bit more efficient. So moving on to the next slide here, just again, kind of high-level benefits of the captive structure. It's leveraging all the benefits of a self-funded plan, but really providing a lot of protection for that bad year, because most groups on average will have 7 or 8 good years out of 10 and 2 or 3 bad years out of 10. So, just think of it that, if you've got a pool of not just one credit union doing self-funded on their own and potentially having that bad year and eating all of that experience, but instead being part of a pool of dozens of credit unions, for every few that have a bad year, you're more likely to have, or just as likely to have a few that have a very good year that offset each other. So definitely helps significantly from that perspective, and certainly leads down a path that has short-term savings from the perspective of you've moved to a more efficient plan, but then that long-term savings potential as well on the more efficient structure, with the protection of having that backstop of your peers to help you when you have a bad year, also with the understanding that some of your peers will have that bad year and you'll need to help them out. So it really lends itself to that credit union collaborative type of spirit that we see so often working with credit unions.
Yeah, thanks, Ryan. I think one topic or another comment I'll just mention there to add on to this is, I think I'd said this before, that these programs, self-funding and captives, are not really that uncommon or new, but you just don't really see it from a lot of carriers and brokers out there. Unfortunately, I think because it really benefits the client, the employee, or the employer more so than the carrier or the broker, because we are really finding ways to buy less insurance, and these are really ways to do that. So a commonly asked question we hear from a lot of HR managers is, okay, if we're working with this captive and moving to this different funding model, is this going to require more resources within my department? And typically the answer has always been no. And we have a lot of good case studies and references and testimonials that can speak to that, because we are delivering some service partners that help with the claims processing and just the administrative side to manage a program like this. So with that said, how about we move to what we call cost containment? Ryan, would you mind taking lead on these next couple slides as well?
Yeah, I will. 2 other things that I just wanted to touch on really, really briefly before we move on to the next section. One, as we look at self-funded plans for credit unions, there are options as it relates to the network, and by the network I'm referring to the network that kind of approves which providers you can go to, which hospital systems, so on and so forth. So we always help our prospective credit unions that are looking at this type of solution to evaluate how that works for them. For the most part, it's very similar to what you have today under a fully insured plan, but and it's usually a large national network like a Cigna and Aetna, something along those lines. The other thing that I wanted to reference is we've been able to structure these self-funded plans in a way to where it acts as something referred to as a level funded plan, and view it essentially like this, that a level funded plan kind of looks and acts just like a fully insured plan, in that you have fixed monthly premiums that are due on a monthly basis. And essentially what happens, as Jesse was talking about earlier, the refunds that can potentially come back, you have 2 opportunities for refunds coming back. One for your direct lower claims experience under your deductible, that if there are leftover dollars there, a portion of those come back, as well as the captive layer, that if the collective group is running favorably, that there are leftover dollars in that pool that can also come back to the participating credit union. So, it's a great situation that flips the tables, as Jesse was referring to earlier. The fully insured carrier kind of always wins. It turns it into a situation where you actually benefit as an individual credit union and as a group of credit unions collaborating by benefiting from your own favorable experience. So with that, I'll actually go ahead and move on to the cost containment and active management side. So in and of itself, the captive self-funded type structure is more efficient, but if we stopped right there, we'd end up being on a path where, sure, we decrease the baseline costs, but we do nothing to impact that trajectory that Jesse touched on earlier. You know, the claims would still continue to go up at the rate that they are. So a big focus for us is finding ways to help the plan run more effectively and efficiently. And, you know, here's, you know, a simple example of that. You know, say an employee needs a knee or a hip replacement, which you'll see the inpatient DRG 470 code toward the top of this graph. That is the diagnosis code for a knee or hip replacement. And what you're seeing here is across multiple different facilities, what their average charges are, what the Medicare average is, what the billed average is, so on and so forth. And the, you know, very interesting component of this is, you know, some of these facilities perform literally hundreds of procedures a year. Some of these facilities perform only a few a year, and the outcomes can actually vary as well. So take a look at it from an employee perspective. Typically, employees, when they need a procedure of some type, they're following the guidance of their best friend that had a knee replacement, their primary care physician who, you know, while they're a doctor, they don't really have a whole lot of insights into some of the statistics that we can bring of who's effective and who's not. So kind of view this as GPS for your employees to help them navigate the healthcare system. So, you know, we've got ranges here of anything from right around $30,000 for a knee or hip replacement all the way up to close to $60,000. And what we can do is, say an employee is going to have this type of procedure, they reach out. We've got an advocacy team that can help them evaluate what providers, hospital systems are in network, who has performed a lot of these types of procedures to get a sense of their experience, and then also looking at some data on the outcomes of their patients, i.e., was it a successful procedure, or did they require, you know, future work on that knee or hip replacement, more physical therapy because it didn't take quite as well, whatever that might be, and then provide guidance to them of, hey, here is a great high quality provider that's in your area that has performed a lot of these procedures, has a great outcomes, and just so you know, it actually, you know, their procedure is actually about $15,000 less than the one that's you know, that was originally recommended to you. And we can put incentives in place that, you know, this is not mandated for employees to go through this, but put incentives in place to where if they reach out, they follow the guidance of the advocacy team, that their deductible or even their max out-of-pocket costs could be waived. And I think most credit unions, you know, on the line with us today, if you had an opportunity to offer your employees an opportunity to have their deductible or max out-of-pocket cost waived, that might total $5,000 or even $10,000, but it saves the plan $20,000. That's something that you'd want to encourage and incentivize your employees to do. So that's just, you know, one example of a way that we can really help employees navigate a very complex healthcare system. A couple other quick examples that I'll share is, you know, one, and both of these are real claim examples. One is dialysis is a very expensive ongoing treatment. Individual here went to a facility. That facility's charges, the amount that they actually billed the insurer, were $1.4 million. The network, of course, you know, they tend to brag about these great discounts that they get, and it's, you know, close to a 50% discount on the billed amount, and the network approved $775,000 for this claim. Through the TPA, which I'll explain in a moment, the TPA is really who manages the claims. Through identifying this high-cost claim and then actually reaching out to the dialysis provider to see if they would accept Medicare rates, they did indeed get the provider to agree to accept Medicare rates, which totaled $76,000 annually, which saved the plan just under $700,000 a year. So, you know, great example of, you know, even in that situation, letting the employee get the services where they had already planned on getting them, but by being more proactive and trying to find ways to manage costs, that you can have a, significant impact on the plan performance. Another example, an individual needing a kidney transplant where, it's a very specialized procedure, and trying to guide that employee toward a center of excellence that really has a lot of experience and, favorable outcomes. This particular person, they were able to direct to Johns Hopkins University, one of the best facilities in the country to have this type of procedure done. They were able to negotiate a bundled contract with Johns Hopkins that actually even included transportation and accommodation costs for their spouse to be with them throughout the whole procedure, pre-op and even post-op. And it saved the plan $157,000. So, they were able to get the best care possible, get support from their family, and it saved the plan a tremendous amount of money. So, it sounds in some ways, I think, at times a little too good to be true, but at the same time, keep in mind that in the fully insured world, the insurance company is not really that motivated to try to find ways to control costs, because they know that they can constantly keep increasing premiums on their customers. And as we, I think one way to look at the solution that we've put together is it's really unbundling the insurance buying process to get the most efficient platform from the insurance perspective, to get the most favorable network options, to put tools in place that typically aren't in place under a fully insured plan, to be advocates for your employees, to help them navigate the healthcare system, and then connected with that, be able to handle claims separately through a specialist third-party administrator that really manages, adjudicates claims, identifies those high-cost claimants, and tries to help implement strategies to control that cost.
Thank you, Ryan. I think you'd mentioned this, but I'll just remind everyone that some of those numbers are pretty staggering, and we work with some partners that see this kind of information every single day. But we realize that every credit union has a different culture, a different risk appetite, and we're not here to dictate where your employees and dependents go and what doctors they see. They can still see whoever they would like, but with a little bit more data and information and resources, there are certainly a lot of examples where we can really help drive down those costs. So we do have a few other slides. We didn't put it in this presentation. One we call the crawl, walk, run approach, where again, we can really meet you at your risk level and your culture level to see what are you interested in? Is it savings? Is it efficiencies? Is it really just the quality of care? And from there, we can look to see if there are additional ways to help credit unions save. Again, without really pushing too hard or too fast. So we'll get to our last section here in terms of enhanced service and support. So once we help credit unions transition to a more efficient purchasing plan, like a self-funded or level funded model, a lot of that really is in the background. You kind of set it, forget it. It's pretty simple once it's running. So I think really what we hear from our clients the most is just the different service levels and the options that we offer. So we'll speak to more of the products we have available, and more so options that we have available for our different clients through this QSO model. And that's really what our credit unions probably talk the most of when we ask them in whether references or testimonials. So Ryan will speak to a few of these. We'll just give a couple examples. Again, want to remind you that these are just options that we can offer. Some credit unions love it. Some credit unions already might have a benefit administration system that they use. So please remember that some of these are just optional, but it's some really good tools, especially for some of our smaller clients that they don't have already. So Ryan, go ahead and take it away. Oh, we lost your audio again.
Sorry.
There it is.
Realized I still have the mute button. And before I get into this, to Jesse's point, all of this is optional. I should specify as well, we've got a dedicated credit union service team that works with credit unions day in, day out, as we would evaluate for a credit union looking at the captive as an example. If it wasn't favorable for a credit union, we'd be the first to tell you that, as well as, for some reason it just didn't match up, you weren't comfortable making a change to it. We do work with credit unions that are inside some of our collaborative solutions, as well as some that, for one reason or another, have not chosen to transition. So I just want to make it clear that we're very consultative as we help credit unions evaluate these types of solutions. And should you ever want to work with us, we can support virtually any platform that you're on. So with that said, again, a lot of what we do is leveraging collaboration between credit unions to enhance insurance offerings, like what we're talking about on the captive self-funded plan, but also leveraging that collaboration to bring tools, resources, technologies to credit unions to help them more efficiently manage their benefits, better educate their employees, so on and so forth. So one of those is benefit administration system. So view that this as the system of record for all of your benefits enrollments. So when it comes to open enrollment, you could have the process, entirely on this type of system, potentially move away from paper enrollment forms if you're doing something like that today, as well as ongoing needs. As you've got new hires, terminations, you can log those into a benefit administration system. Oftentimes, there's also integrations that can be done between a benefit administration system and your payroll provider that can add even greater efficiency to managing your benefits, managing benefit deductions, so on and so forth. So we can bring that to credit unions to add quite a bit of efficiency on that side. One thing that we often do for credit unions is offer additional support outside of the enrollment on the benefit administration system, to where, say, an employee has questions on different plan options, or maybe you don't even offer options. They just don't know how the deductible, co-insurance, co-pays, whatever it might be, how that works. So employees going through the enrollment process can actually reach out and contact a benefits counselor that can really walk them through the options, as well as answer any questions, help provide them with guidance. So, we very much feel that, especially for the small and mid-sized credit unions, going through the enrollment process is such a big lift. And a lot of what we've done is trying to find ways to support your team through additional resources and technologies that can really lighten the load for your team. On top of that, we provide a tool that's called ThinkHR that is essentially, I like to kind of describe it as phone a friend for HR related issues. And they don't have to be benefits HR related issues. They can just broadly be HR issues. So ThinkHR is staffed by SHRM HR certified experts that, should you have a question of any variety on the HR side, you can send it to them via phone, email, submit it via the website. They'll have their folks do research on that, come back to you with source information, and provide you answers to whatever that question might be. So in a lot of ways, it's kind of like you've got this assistant out there that can do the research for you when you need it, but not have the overhead of actually having to pay someone to do that. Past that, there's all kinds of other tools available through the system, everything from compliance tools to training tools. So it's a pretty robust system. And again, especially for the small and mid-sized credit union, a great way to kind of supplement with some additional expertise without the overhead of actually having to pay someone to do that for you.
Okay, thanks, Ryan. So
yeah.
So let's continue on. So I guess in terms of when, we've been working with a lot of credit unions throughout the past few months. A lot of them have sent over data, census information to help us evaluate the best options for them. That would be the ideal next step. We have what we'll call a data request email document that really shows exactly what we need from each credit union if you're interested in evaluating this type of program. And what we're asking for is pretty typical in terms of what any other carrier might ask for if you're evaluating different carrier options. Again, census information, some carrier statements, things that help the underwriting team really put together some competitive numbers. So that would be an initial next step, as we're still collecting a lot of data and really finding the right collaborative model for a large group of credit unions. We expect to begin to propose numbers, quotes, pricing options to credit unions really starting the next week or so, probably up until November 15th. I know that we'll be cutting it close for some credit unions, but we also know, most credit unions have that January 1st renewal time frame. A lot of credit unions are still sending over their data. So, we're still open to receiving information, quoting that out, helping you really look at, what a captive model help your credit union. And if not, we still offer several different models. We have found some of the smallest or even some of the largest credit unions are still might be better off in a fully insured model, and we can just help leverage different pricing, different service components within that model. So whatever it is, we can certainly take a look and help you out. But this would be the ideal timeline in terms of us looking at the numbers, getting back information for each credit union to really fully evaluate the options and have enough time to make sure that this is the right fit for your credit union. Ryan, anything you want to add to next steps?
Not to next steps. I just did get a question submitted to me, which I can answer in a moment. But yeah, I think you summarized the next steps perfectly.
Okay. Yeah, and we are kind of winding down here. We only have a couple slides left. This is, I think, more so speaks to, again, that first slide I presented of that trajectory of in medical insurance costs, claims costs really going up and up and up. And you'll see on the left-hand side a pretty familiar conversation I'm sure we've all had about, hey, it looks like your health plan is only increasing by 6% this year, and we can further minimize this by increasing copays again and deductibles and premium contributions. It's not the conversation we want to continue having with credit unions and with employees. We really want to have more of a conversation of, hey, your employees are leveraging your health plan more efficiently, and that's turning into real dollars and savings for your credit union. And we want the trend to look more so like the right side of this slide as opposed to the left. But again, that it requires a little bit of different evaluation, considering a different model compared to that fully insured market. So again, that's something that we want to help credit unions evaluate. Lastly, this isn't intended to be a sales pitch. It's just showing that we certainly do have several credit unions, large and small, that are working with us. We have a lot of good references and case studies. Would be happy to send any of that out to credit unions if you're interested in speaking to other like-minded, similar-sized credit unions that have made transition over to our eye care solution. So please know that we have some good resources and references available for you. So Ryan, it sounds like you had a question typed in. I had actually a question typed in. I'll certainly want to address as well. And again, if you want to open up your lines, feel free to chime in, unmute and ask questions, or feel free to chat any questions in. We have a few minutes left to address those.
Yeah, so I individually replied to this individual, but I think others might have had the same question. It was a great one of, do we have the ability to support like a high deductible health plan under the level funded type of solution that we were describing? And absolutely we do. Shame on me when I was sharing some details on network flexibility and kind of highlighting the level funded structure of this for not touching on this. Under these types of plans, typically there is a near infinite amount of flexibility as it relates to the plan design. So we can, a credit union that's got a very rich copay type plan today that wants to maintain that can really do that, and it can be supported under this type of platform, as well as, the other end of the spectrum, a very high deductible health plan with more out-of-pocket costs for employees. That's going to be a lower cost of insurance typically, can also be supported under this type of plan. So I'd just kind of broadly say, for the most part, it's just about as flexible of a solution as you're likely to encounter. And I should actually expand upon that. If groups want to have multiple different plan designs, we tend to advise and guide away from doing 4 or 5 different plans, but it's not that uncommon for credit unions these days to have 2 different plan design structures, maybe a higher deductible health plan option that is a little bit more aimed at younger employees who are more concerned with minimizing out-of-pocket costs to actually get their benefits coverage, and they don't feel they'll use it as often to where they can start putting money away into an HSA account and take that type of strategy. And we have credit unions that do that across their whole employee base. And we have some that want to offer a buy-up option where it's a lower deductible, maybe even a copay type plan where it's more geared toward the employees that plan to utilize their benefits more often, utilize the health insurance more often, and they're willing to pay a little bit more out-of-pocket cost to buy up to that type of plan. So that type of situation we can support as well.
A good point, Ryan. One of the questions that was typed into me was just asking to define the size, small, mid-size, large, and that can be sometimes difficult to answer. Only because we have some smaller credit unions that really transitioned well into a level funded plan, and we have some large credit unions that still wanted to maintain a fully insured plan. So sometimes it depends on your size, sometimes location. A lot of times claims activity will dictate what the best plan is for you. So it's the captive model, again, typically works best with maybe 10 to 20 employees, upwards to a couple hundred employees. We do have, again, a captive model available for some of the very larger credit unions with 200-300 plus employees. So we can really take a look at your size, your shape, claims history, your risk appetite to really find what might be the best potential solution. And we really believe either way, there could be some purchasing efficiencies that could be gained, and through our active management type partners, there could be a lot of resources that could be gained for your employees as well. So let me pause again if there are any other questions. I'm not seeing any chatted in.
We do have one. Let's see. One question is this just for medical insurance or all of the insurances being offered to employees? In Vermont, we only have a couple of carriers that we work with. What carriers do you work with?
Good question. Thanks, Christine. I just saw that come in. Yeah, good question. I think, Ryan, do you want to take that? And maybe I'll give the short answer is yes, we can certainly take a look at all different insurance plans. Usually the cost savings is certainly on the medical side, but we happy to take a look at all different options. And in terms of carriers, that sometimes depends, but we do have a couple of national carriers that we work with. Ryan, do you want to explain some of the different carrier options that we've worked with?
Yeah, we could name names, but it would take quite a while. But I'll mention some of the top ones that we tend to work with are the Cigna, Aetna, United Healthcare, a lot of the Blue Cross entities, so on and so forth. I will say, groups that have looked at different fully insured options in certain geographies where a particular network tends to be, or a particular insurer tends to be dominant, and they've kind of felt stuck with that insurer. Oftentimes, when you look at level funded or self-funded options, the opportunities are larger, largely just due to the fact that by moving to a more efficient structure, by putting some advocacy measures in place, like we touched on with the knee replacement, the dialysis, so on and so forth, that some of the minimal advantages that some of the fully insured carriers have in some markets can be largely kind of wiped out, that discount advantage through other structures that are put in place. The one thing that, we don't run into it very often, in fact, it's incredibly infrequent, is if there is a network that has their own insurance solution that has a stronghold on a particular hospital system, as an example, where you can really only go to that hospital system if you have this one network. It's rare, but it can happen. But that's something, we tend to be able to figure out pretty quickly through the evaluation process of, is this even a viable option for you in your geography with the makeup of your employees and where they tend to go to get their health services.
All right. Thank you, Ryan. Thanks, Christine. So I think that wraps it up. So you have my contact information. Feel free to email me with any questions, but of course, feel free to reach out to Christine and the association with other questions as well. I want to thank again, Christine, for hosting and coordinating, and thanks, Jackie, again for helping put all of this together. This is exciting for us to really work with even more credit unions across the country because, again, as I mentioned before, collaboration, volume, law of large numbers, that all really helps credit unions and it benefits your members or your employees so much. So want to thank you all for joining us and happy to stick around for a little bit more if anyone has any questions, but otherwise I'll turn it back over to Christine to close things out.
Well, thank you. I really appreciate your time, Jesse and Ryan. It was very informative. I found it very interesting to find out that hospital charges different amounts for services. It's like I would have thought everything would be, the same no matter where you go to get your health care. But if anybody does have any more questions for Jesse and Ryan, Jesse's phone number is right on the computer. And he will be glad to help you out with anything and help you decide if it's the program for you.
Thank you, everyone. Have a great rest of your day.